The Nurse Practitioner in neonatology started in the 60s in the US. They were the first group to ever exist. And in our unit here, we started back in 1994 as a group, hospital trained. And then we completed our masters by being recognized by US University and so on. As long as his airway is safe, that's the main thing. And once that's done, we can work on the rest. But in the meantime, if you want to learn how to do the gavage, feel free. I can tell the nurses, they will teach you how to put the tube. We function very similar to that of a resident. Some will compare us to like an R3 or a junior fellow if you want. And we follow patients on the unit. The advantage that we have is that we bring a role, it's a combination of nursing plus medicine combined together to give you an approach that's quite unique as to how you take care of the patients. Your ability to communicate with families and develop relationships with them, which are based on your nursing background. And then you have your medical background that you kind of completes the picture. Also taking care of the patient as a whole, which includes the 5 acts that we're allowed to do, which is carry out procedures, write out prescriptions, order tests, interpretation, and medical treatments as well. I think the families and nursing on our unit appreciate the role that we provide. Many families, when they've been here for a period of time and have been covered by residents in which they change every single month, if we pick them up for a short period of time, often request that we keep them thereafter.
I find it very helpful actually. Whenever, of course, our unit is crazy busy, so our staff isn't always available to run to ask questions. So it's definitely helpful that they're usually right near us, so we can ask them for any orders to be written or any suggestions. They're usually pretty available for extra help. Same thing.
Yeah, but after 11 years of working here, we've developed a very good teamwork, and it's very good because they follow a lot of our chronic babies. So there's a lot of continuity. So even if we don't work for a couple of days and we want an update, they're always right there.
Yeah.
So it's very good, and it's a very good support. Like she said, they're always there. They're very knowledgeable, and they're very available. Even though they're not in the unit, and if you have a question, just run to their office, which is not very far, and they'll be very happy to help you.
The nurses get to know the child, so there's a relationship there. They see the progress, if there is one. Very open about what the diagnosis and progress of the child is. So it makes it a little easier for us, the parents who might not be here early in the morning when the child is being checked by the doctors, and then we sort of miss each other, to have that intermediate person there that basically can fill us in as to what happened during the day when we weren't here.
You'll always see them at the bedside. They're very available to families at all times. So
yeah, and like I said, with the continuous relationship with the family, they don't see different faces, so it's very good that they're there, and so the trusting relationship is really built right from the very beginning until they go home. So that's a really special thing that that they could offer the unit.
OK. Je vais regarder votre radiographie des poumons. Je vous donne des nouvelles. Je reviens. I care for all the patients in cardiac surgery, the pre-op and post-op patients. So I see patients upon their arrival here on 3 West. I do the pre-op admissions. I make sure that patients are ready for surgery. And then once they come back to us from the ICU post-operatively, I take care of them right until discharge. So this includes any kind of testing that needs to be done, any medication changes, issues with family discharges, all of that goes into how I care for my patients. Mais là, je vois que vous êtes un petit peu essoufflé.
Oui, parce que j'ai fait quelques efforts tout à l'heure.
Oui.
Et puis là, faut que j'attende que ça se replace.
OK. Mais là, vous m'avez demandé. I enjoy working with the patients, the families, the physicians, and I find that working with all the cardiac surgery population, I have a global view of everything that's going on, and being able to follow up patients on the long term, as opposed to only having that patient for an 8-hour shift and then maybe not seeing them again. And so I like more the continuity of care that the the practitioner role allows me. On va voir avec ça si on doit changer la médication ou bien parce que des fois après la chirurgie, il y a un petit peu d'eau qui s'accumule dans le poumon.
Oui, c'est parce que mon gars des poumons, mon médecin, il m'avait. J'ai été quasiment mort, là.
Alors, avec la radiographie des poumons, on va voir là, qu'est-ce qu'on va faire, comment mieux vous améliorer.
Ouais, j'ai confiance.
Oui. Bon. Puis après ça, autre que l'essoufflement, comment ça va?
Ah, voilà, ça va bien.
Oui.
Oui.
Hein, commence à reprendre des forces.
Oui.
Vous avez super bien fait ça avant la chirurgie.
Oui.
Hein? Vous étiez en bonne forme là, avant la chirurgie?
J'ai été chanceux, vous me l'avez fait. Moi, tout ce que j'avais à faire, c'était d'être patient.
C'est ça. Un patient.
Oui.
Oui. Ah oui. All right.
When I saw that, I was like, oh, it all makes sense, because I really, okay, I wonder what's going on. It's very helpful. We sort of work as a team, and I ask her lots of questions, and anytime there's any concerns about the patients, or even to discuss the patients, she's right there, she's accessible, she's a wealth of knowledge, she's great.
That's his stomach there, but look, he has little tiny lung volumes,
Yeah.
which is exactly what we've been
Yeah,
seeing,
yeah.
but he's quite fluid overloaded too.
Okay, the gray fluid, I can't
Fluid.
tell,
Yeah, the gray is all the fluid.
but he sounds crackly, so I
Yeah.
figured that's fluid because I saw your note also. Because I'm new on this unit, I've never actually worked with cardiac patients before, she helps me I mean, generally I know what I have to do, but if there are any specifics, if I, listening to someone's chest, I ask her, what does that sound? Can you listen to this? His lung, I mean, it should be bigger, right?
It should be way
bigger.
because he should have at least 8, 9 ribs, and we only see 1, 2, 3, 4,
is that how- okay.
5. You only see
Okay.
5 ribs, so he's not taking a good breath at all.
Sense.
Yeah,
How am I
That
going
is-
to take a big breath?
we'll need to diurese him a little bit more and really get those.
Okay,
Yep.
very
Perfect.
good.
Thanks,
you.
Debbie.
It's easy, it's quick, and you really get to brainstorm very easily. And with this particular patient, I listened to him, it didn't sound quite right, I had some concerns, and I saw that she ordered a chest x-ray, so she was right there to discuss the patient. And everything we clinically saw, and then she showed me the chest x-ray, made sense. So together we have a plan. Medically, she'll get rid of some of the fluid. I will try to help the person take bigger breaths and encourage breathing and all that stuff. So it works together in the best interest of the patient.
I feel that I've contributed to the patient population by making sure that the patients are ready to leave. So even though our length of stay may be 1 or 2 days longer than they had been previously, the patients are ready, everything has been followed up on, and which helps with the decreasing in the readmission rate, which had been an issue in the past. As well with the continuity of care, patients know that they're being followed day after day by the same person, and this has also contributed greatly for the patients in improving their quality of stay.
Hi, Caroline.
Hi.
How are you doing today?
Hi.
Good.
Yeah.
Are you feeling well?
Yes, I'm plenty better.
good.
Yes,
Fine.
plenty
We've had the
better.
nurse practitioners for about a year and a half now, and various stages. When we were at Saint Roseau, there was a 6-month period, but since we've been at Saint Roseau Intégré officially in February 2010, you could say they've been working with us more officially.
I'm just quickly going to go back up over your meds because I know that you met with Sylvia, the pharmacist, and there
Yes.
might have been some changes or some reviews since we last visited.
Yes, yes.
They're functioning like physicians, if you ask them, which is very happy for us, okay? And it's interesting that patients have responded to this absolutely with joy.
Can you tell me what it's like to be cared for by a nurse practitioner?
Yes, it's very nice. It's comfortable, more relaxed everything. Good treatment, good relationship between us and so.
What's your relationship with Kelly?
Well, we have a good relationship, a good understanding. She told me everything and what is right, good for my health and so.
We're absolutely delighted because the nurse practitioners have stepped in and they are following up on, in very many instances in the follow-up clinic, difficult patients who we can't place with family doctors, okay? That in Herzo, our family medicine unit, and we have 20,000 patients. I call it the Herzl Golf and Country Club, because as opposed to 40% of the population in Montreal, the patients there have doctors. Kind of tragically, what we have here is a walk-in where our Herzl patients, when they're acutely ill, come, and any of 230,000 people in the CSS de la Montagne and 3 million people in Montreal, many of whom don't have family doctors. We try and squeeze the vulnerable patients, the ones who are more ill, into Herzl, but we can't squeeze in everybody. But we do have many of them who've become patients of the nurse practitioners. And vulnerable means you have any one of about 11 serious diagnostic entities like diabetes, cardiovascular disease, and these have become the mainstay of their practice. So we appreciate them enormously.
I'm one of 3 primary healthcare nurse practitioners, and we work in collaboration with our physician partners to really provide primary healthcare to various patients in the area, and it can range from newborn babies up through to the elderly population. So we work with patients with diabetes, with hypertension, and just try to help them manage their condition.
And you'll feel better. The more you get walking and that stuff, like keeping up your exercise, you'll feel better as well.
Yes.
Okay.
Having the nurse practitioners as that second line safety net behind the physicians who are doing the walk-in clinic really allows us to follow up on patient issues, have continuity of care, and once one issue is started and investigated, the nurse practitioner can really pick it up and say, okay, well, you came in for this, but let's kind of do a summary of your entire health profile. Where are you at? How are you feeling? How is your health in general? And do a thorough examination of the patient to provide holistic care and really get them set off in the right direction for their health.
If your blood pressure is still climbing with the hydrochlorothiazide, and now that we have, we call it an ACR or
Our patients seem to love the role of the nurse practitioner. They don't always know what a nurse practitioner does, so there's a lot of education and teaching about what the role is and what we can do and why we're different from a nurse and why we're different from a doctor, but how we can blend the role together to really be their primary care provider. And once they get comfortable and really understand who we are, it's been a fantastic experience both for us and for the patients and families.
Caroline, this is Dr. Malus.
Yeah.
Hi, Caroline.
And
Hi, Dr. Malus.
Okay.
So Mrs. Isaacs is a 60-year-old woman that we've been following here at the CRIU for following her for diabetes.
For how long about now?
We've been following her.
The benefit of being a walk-in clinic is there is always a physician on site, and we have an attente with our physician partners to be able to be available to us when we need them. Typically we don't need them for every patient, but if there is a certain issue that we need to consult with them for, they're available for us to go and give our patient history and present the case and suggest the treatment plan that we would like. For example, if a hypertensive patient or it's a newly diagnosed patient with hypertension, we've been following them and we've made the diagnosis of hypertension, then we consult with our physician partner to say, do you agree with this impression that we've made, and can we go ahead and start them on a blood pressure medication?
For her diabetes, we've sent her to Dr. Dannenbaum in our diabetic clinic, and he started her on NPH at night, which
we're able to work
seen
independently on our own with the patients, but we have the great opportunity, and that's the whole idea of a nurse practitioner, is that we have that collaborative practice with the physician, so they can be doing their work and their job, and only when we need them do we kind of go and seek their opinion on something that we're not sure about, or that just by within our scope of practice we need to have their agreement in their diagnosis or to start a certain medication with our patients.